Welcome, everyone. My name is Dave Arnold. I'm the Executive Director of NextGen Precision Health. It is my pleasure to kick off the next Discovery Series. This is our flagship seminar, and we have a fantastic speaker scheduled for today. I do want to mention we have transitioned to the Mentimeter for our question and answer part of today's talk. This is really the most important part of the talk, is where we kind of create a dialogue. And so if you see on the screen there, you can use the QR code to get the link there, or you can input the code and submit your questions that way. And so please do that as you go through the talk. And people that submit questions can be upvoted. So if there's a question that you like, you can say, I also want that question answered. And so try to upvote questions that are most important to you. So it is my honor to introduce Dr. David Fleming. Many achievements in his career, and really great to host him for this talk. So Dr. Fleming earned his medical degree and completed his internal medicine residency here at MU, joined as faculty in 1980, and served as chair of the Department of Medicine for 10 years. He has many other things that he has achieved. He was a lead editor and author of the book Care of the Dying Patient, which is relevant to what we're going to learn about today. Has also was served as the president of the American College of Physicians from 2014 to 2015. Currently, he is a senior scholar at the MU Center for Health Ethics. This is where he previously served as a founding director in 2001. He is currently the chair of American Medical Association's Council on Ethics and Judicial Affairs. Dr. Fleming's career has focused on clinical medicine, and his research has focused on largely on end-of-life care, health disparity, health literacy, and healthcare access and research ethics. And so it's a great privilege to welcome Dr. Fleming as a physician that takes care of a lot of patients with diseases that really, I tell people, I feel somewhat helpless taking care of. The one thing we can do is help people experience less suffering. And so very excited to hear this talk today and to learn about how I can do that better.
Thank you, David. Appreciate it. Yeah. Thank you, Dr. Arnold. First, can you hear me well enough? Both here and out there. To have a lead in with a fantastic presentation to come, no pressure at all. Not to mention the fact that, I look around this room of brilliant minds who are creating the science of the medicine of the future for the welfare of our patients. And here I am as really a community-based general internist who does a little bit of geriatrics and tries to teach some bioethics now and then. It's a little bit daunting, I must tell you. But the main thing that's kind of terrifying is I look around and I'm seeing me looking back at me. So I want to try to move along on the slides so that we can get this done. I do want to say that I look around, I see a lot of familiar faces. I see colleagues, I see friends, I see neighbors. I know there are maybe a few of you out there in cyberspace listening in and watching, and I feel your presence. But this is a little bit different than many of the talks that you probably have heard related to a lot of the basic science that's being done and the work that you're doing. What guides me in my discussions always is who I am as a physician. My past history as a general internist, being a community-based physician, caring for patients, and caring for patients at the end of life is really what informs literally all the work that I do. And so you'll probably sense that as we work through this. We have a few cases to discuss, and hopefully I will learn from you as you teach me about some of the issues that we're going to be talking about. This is a talk about research ethics, but not in the traditional sense. This is a discussion about a domain of medical research that has evolved and expanded to such an extent over the past several years that it really does place the research team squarely at the bedside. It really brings you into the care environment at a time that we really need your input with all of the changes that are taking place and challenges that we confront in healthcare. As such, as you join us we the clinicians at the bedside, we share in the normative processes, the normative expectations of what that means in the care of the patient. Part of this is going to be attempting to define futility and what that means, and I think that's going to be important for the questions that I'm going to have for you as we move forward. Let's start from the beginning, certainly from the foundational beginning and the foundation that we all stand on, which is, this is a quote from Ed Pellegrino, who tells us that the first principle of medical ethics, the end to which is directed, is the good of the patient. And indeed, indeed that is the goal that we all have, is improving the state of humanity, improving the welfare of our patients through wellness programs and through curative programs that we have there. Human subjects research actually was born out of abusive behaviors in the research environment, in the research domain. You know this probably better than anyone in the history that you have read and you have written about in the work that you do. It has produced several guiding principles that we use in the research process, but you know this has transcended in the epoch of translational medicine to a very different kind of relationship with patients and with our research subjects. Because indeed, our patients are our research subjects in a lot of the work that we're doing now. When we talk about big data, how we deploy big data, how we utilize medical information, and how we use personalized healthcare and personalized medicine, and all of those science vectors that take us in the direction of taking care of that singular patient. It promotes more direct discovery and to care, which is bench to bedside, which is the adage that we use frequently, and now requires collaboration of researchers and clinicians at a level that really is unsurpassed historically. The patient-centric therapy using specific biomarkers is what precision medicine has done, and this has really taken it to the next level. Tremendous innovative changes have occurred. They're occurring rapidly now with the advent of AI and the capability of garnering data and making analyses much more rapidly than we have in the past. But this has come with challenges. It's come with challenges in our need to get much smarter. Certainly I need to get much smarter, which is a challenge for me. We need to collaborate. We need to acquire new mindsets in terms of who really is within the relationship with our patients. Making patients more aware and accountable themselves in that partnership that we have with that trust relationship that we invite in our healing relationships with patients. The global sharing of data, which occurs tremendously, which brings to mind how do we get permission from our patients to use that global data that once it's out there. And that's one of the challenges that we, in fact, are dealing with now in the AMA. But clinicians and research must really interact at a much higher level now. We've had these discussions. I mean, Steve, you and I have had that discussion several times, have we not? In terms of what you do and what I do and how we can meld that and how we can make that happen at a much higher level to create more beneficial outcomes for our patients. When we talk about the ethics of precision medicine, there are many concerns that are there. Data integrity, how we interpret the data that's there, this massive amounts of data that is often coming in. Do our healthcare systems have the capacity to absorb this and to use it effectively? Of course, safety and regulation is always there. And what is undeniably a challenge is the influence of industry and the conflicts of interest that are often there when there's big money that's involved in utilizing this kind of science. But the impact on the care environment is really what I want to talk about. It's the impact of what you do and what I do and what others in this room do at the bedside with our patients and how we communicate their situation and their potential outcomes from the interventions that we have to offer there. Trying to find a shared understanding through communication with our patients and invite trust that information is going to be helpful and substantiate the hope that they have. What is the impact on future generations, on our families? Fair representation of the data. One of the challenges I know that that many of our data sets have is that the fact that we have underserved genetic pools and that we may have a skewed representation of the analysis that's there. And then, of course, fair access. It's estimated by the IOM that only about 6% of those who are eligible to benefit actually do and actually have gain access to this. So we need to do something about that. And that's really at the policy level. And then the financial burden speaks for itself. Who's going to pay for it? Are you going to pay for it? I'm not going to pay for it. So we have a shared commitment. You know, we truly have brought the bench to the bedside. We're there together. We link arms in a collaborative commitment to the good of our patients, to seeking good outcomes. And the good outcome doesn't always mean cure. The good outcome may mean excellent palliative care. It may mean knowing when to call the question in terms of how and when certain kinds of interventions and therapies are deployed. And we're going to be talking about that further as we talk about some of our cases. And this extends through the spectrum of life. This isn't just at the beginning of life, as it relates to genetic screening. It's not just in the sort of the middle of our life when we are relatively healthy and we're getting interventions on treatments that are there that are potentially curable, but it's also at the end of life when cure is no longer possible, when degenerative processes are in place that are irreversible and that we have to confront and deal with very openly and very compassionately with our patients. This is a case, and all these cases that I'm going to share with you are consults that we have done. And you'll notice that I have my ethics. Who did I tell you that was going to screw this up? Do I know how to do this? Is that good? Okay. Yeah. Sorry about that. I have my ethics colleagues here, Dr. Brandt and Ali, who's our administrator. Dr. Brandt's our center administrator. And you know, with the center here, I always like to say, you know, we're like the government. We're here to help you. So, you know, that's supposed to be a joke. But they're also my fact checkers. So on any of these cases that I'm off the mark on, just let me know. So this is a 6-year-old boy with Niemann-Pick disease type C that you probably know a lot more about than I do. Those of you that are interested in these inborn errors of metabolism and interventions that might be there, who has had this since birth. Usual prognostic outlook for them is about 5 years. They rarely survive beyond 5 years. This boy has been in our PICU for almost 2 months. Multi-system failure, vent support, virtually every organ is involved, eyes, ears, all the way down. And the team has done a superb job in keeping this young man alive, but he has deteriorated to the extent that it's a point of no return for sure. They're considering other options like tracheostomy and a gastric tube for feedings, but the mother and grandmother are there and insist on continued treatment, insist on continued support. And the main reason is they know the prognosis, and they know it probably better than anyone, is their hope of cure. They know that research is being done. They feel that there may be something coming, and that they are the hope of discovery and the hope of the cure, they feel it may be right around the corner. And they don't want to lose sight of that. Palliative care has been consulted and are attempting to provide intervention, which is challenging. This is complicated by Simon's Law, which Missouri and Kansas have, which prohibits withholding CPR in children without the written consent of at least one parent or legal guardian. So this has been sort of a relative stalemate area for which there really is no effective solution that is there. I talked about our center. We have had a lot of individuals who have been involved. One of the core components of the services that we provide, which is multifactorial, is our consult service. And since the inception of our center in 2001, we've had a steady rise, and as our teams have gotten used to the fact that we actually have a consult service and that we are available 24/7, we have been getting more and more. You can see that we had a significant bump, not surprisingly, during COVID. but that trend has fairly stabilized, I think, in terms of the numbers that we have had. And we think that there are probably a lot more out there that we're not getting that are there. The ethical conflict is invariably related to decision-making capacity, surrogacy on decision-making and representing the patient at the end of life. This is a theme that repeats itself over and over again since we started doing these. When I ran the consult service at Georgetown during my research fellowship, that was the same theme. End of life remains the most conflicting situation that we deal with because of the disagreements and the conflict that arises both within teams and the patients. This is often what we end up with when we get consulted. And this is what we often walk in and then we see. We see a patient that's often been treated for both their chronic and their acute overlying conditions long term. They're in a situation now where they're at a stalemate. They're not sure what to do. The patient in many ways has become part of the technology, and no one knows how to go from here. The questions about withholding and withdrawing become very tempestuous, if you will, in trying to reach the dignity of that patient and what is really, truly in the best interest of that patient. This is a case that I call the Christmas present. I was on call. It was Christmas. It was Christmas Eve, 4 o'clock, and I get a call from the MICU. And had a 38-year-old mother and wife, end-stage lung disease due to pulmonary fibrosis, tracheostomy in place, was on chronic home vent on the transplant list with no real hope that she was going to get the transplant because she had wasted to an extent that she was really no longer a candidate. Repeat hospitalizations for pneumonia. She was back in our ICU now. This is the first time in our ICU on a vent and recovering. She made the decision and had actually been trying to get other teams and other systems to listen to her to say, I'm done. I want to come off the vent, and I'm ready to let nature take its course. Well, she was recovering from her pneumonia. She was stabilized on the vent. She certainly had decision-making capacity. And, she was ready to die. She was done. Well, you can imagine what the husband and her children were dealing with, as well as the team. The controversy here was, treat or let die. And ultimately, our obligation was to respect the wishes of the patient, which is what we did. Very, very challenging case. Not really typical of a lot of what we see on our consult service, but there we are. But ethical conflict was there nonetheless. The one question that arose was, does she have decision-making capacity? Does she have a full understanding? What is the sense of loss of hope and trust that she or the family may have, which often is the case when these controversies arise? And then fear of abandonment. When we're talking to patients about withholding CPR, are we going to be having a cup of coffee someplace while they're in the most desperate time of their life, when they need us the most, when they're actively dying? These are comments that have been made, and these are comments that we often hear. Care team distress, fatigue, and burnout is becoming more and more evident. Certainly through COVID, that has been the case. Communication breakdown is a common theme throughout, and part of our educational training processes is how do we enhance communication? What do we do? How do we get the right information to the right people, including our patients and families, to make those decisions so that we don't have unintended consequences like sustaining individuals sustaining their suffering in situations where medical futility is truly definable for them, especially when they no longer want that intervention, that kind of an aggressive intervention. Sources of miscommunication are many. Death is always near when we talk about complex illness. even if it's treatable complex illness that is irreversible, the notion of death and the question of finitude is always there in the minds of our patients and their loved ones. We accept the incurability of chronic illness. However, we continue intermittent treatment for the acute illnesses that overlie that. And we have questions about futility that arise in the acute care setting, and oftentimes the futility question is about their chronic condition, while their acute illnesses, their pneumonia or their sepsis or their fractured hip or whatever, they're recovering from and they're getting better on. We often consult palliative care too late. We don't bring them in early enough. We have a superb palliative care group here in our system who is very busy. Thankfully, they're very busy, and they do a tremendous job. But we need to get them engaged in that dialogue soon enough so that they can have the discussions with the families, with the teams, with all of the stakeholders when things are less frenetic. Confused messaging on limiting treatment and what that actually means and why we do that. We don't really specify oftentimes, both objectively and subjectively, what we mean by that and what our intent is. And we often don't know what the patient's preferences are. That is a serious problem. We don't have those discussions soon enough. That's even a more serious problem. If we had the decision soon enough in the outpatient setting rather than the inpatient setting, if we did a better job in getting both written and oral healthcare directives available to us so that we actually know what the patient's preferences are, the conflict and the chaos might be less of a concern in the acute care setting. This is a 79-year-old gentleman who's been on our service for 3.5 months. Multi-system failure from everything, most specifically for diffuse vascular disease. A DNAR order, do not attempt resuscitation order, and palliative care are recommended, but have not been deployed yet. We've had 3 ethics consults since admission. I think when I saw this case, I was the 4th consultant to actually see them, and we all kind of said the same thing each time. Came from a long-term care facility on hospice following a stroke that he'd had in January. No written health care directive. The wife is exhausted. She doesn't want us to call anymore. The son has sort of taken over as his surrogate, although he's not the durable power of attorney. He's not the official sort of legal surrogate. You know, there are only 2 kinds of what we call legal surrogacy, and that's when the patient assigns someone, names someone on a document that they sign and get notarized, and then when the courts assign a guardian. But otherwise, we sort of assume that the family members are going to speak for them, or people who are close to them, and oftentimes finding them is very, very difficult. The care team obviously is exhausted. In fact, there are a few cases like this where the care team is not exhausted. Compassion fatigue is a very real phenomenon on our care teams. And Dr. Nakvi, who developed our hospitalist service, and I have had many discussions about this when he was running that service, and it's very serious. The potential guidance that we draw on could be from an out-of-hospital DNR order that he had signed, but was not officially authorized by the physician with him. So the question of legality was there, and whether he had made verbal comment. So you can see the milieu within this context. This is more typical of the kind of things that were there. So much could have been done ahead of time to impact the communication with that patient. Integrating palliative and curative care is a challenge. Knowing when to do it, knowing is it too early, are we waiting too late? My suggestion has always been, if you think they may need it now or in the future, you're already too late. They probably already need it. And as you look at situations where they're heading in that direction, you probably should pull the trigger on it. Moving from disease-oriented to symptom-oriented patient-focused care is challenged because oftentimes that looks like we're giving up. Looks like we're abandoning the patient. You don't want to take care of us anymore. And communicating about that and trying to right that ship can be very challenging. spent about 35 years recognizing the fact that I cannot prognose very well. My prognostication skills are not good. And that's because I'm always wrong. I'm always wrong. Whenever I tell a patient, well, I think maybe 4 to 6 months in our discussions about end of life. They end up back in my clinic a year and a half later and thank me for the great hospice care that they got, that saved their life. When I tell patients they probably got a year or two, oftentimes they're gone weeks or months later. That creates a tremendous amount of confusion and really does impact the trust that they have with patients. In studies that have been done, we found that we're typically over-optimistic, and the longer we have known that patient, the longer we've cared for them, the more optimistic we tend to be in the information that we give them. Why do we do it? Because we also have hope, and we want to instill hope in that patient, not to give up, because we feel that that may have a detrimental effect on their therapeutic response. Informing patients about prognosis in very real, objective ways can have an impact. And we can sway their thinking in this. However, even though many will change their mind about, and this is particularly about CPR, after being informed, there still are a significant number, even in the frail elderly, who still want CPR. They want to give it a shot. I've been a patient. I've had that asked of me, and I'm old. That's also a joke. And I, laying in that bed, with that resident coming to me and saying, "Do you want CPR if we need it?" I was startled. I was the patient. I was not the physician. And I said, "Of course I want CPR. For a while. Don't go overboard." So that mindset is very, very important. And what I tend to do is take DNAR off the table if it becomes really a conflicting process, because ultimately it will be our decision as to how far to go with that. But patients still have hope, and they hang on to that, and they want to pursue that. Lots of misunderstanding about end of life. There is a connotation that allowing death equates to causing death. I don't know how many times I've heard family members or other loved ones say, I just can't make that decision because I'm afraid I'm killing my father. That's very real. And when their father is gone, they have to carry that guilt with them ongoing. And that's an extension actually of the patient's autonomy. That's an extension of the compassion we have for that patient in caring for that individual during the bereavement process. We have this notion of double effect, where aggressive palliative interventions may actually speed the course toward death. We accept that. We know that that's going to happen, but that's not the intent. This actually is one of the oldest doctrines in healthcare that came about in the 14th or in the 15th century that relates to intervening with the intent of helping the patient, knowing that the bad effect, which might be death, may come earlier than you might expect. Very difficult for patients to understand that, and oftentimes difficult for the care team to really embrace that. Patients will refuse reasonable treatment that they see as burdensome, and we oftentimes feel like they're committing suicide when they're making an autonomous choice based on what they feel is important to them. I've still had patients asking for help. Can you speed this along? I know I'm dying. Can you make this happen a little quicker? And what they're asking for is help in dying. PAS is legalized in 10 states and in the District of Columbia. The question there is compassionate aid of that nature incompatible with my role as a healer? The AMA says it does. Our procedure, the council I'm on, Russ has been wrestling with this for 6 years in what AMA's stance should be on this, and there's a lot of controversy about that. And then claiming futility due to poor quality of life is a statement that I also hear as well. But the question then is, who is making that determination? Who is defining what that quality is? Futility, likewise, is one of the oldest criterion Hippocrates tells us that we should refuse to treat those overmastered by their disease. That's what the good physician does. This was 2,500 years ago when we didn't have ventilators, dialysis, ECMO, fourth generation antibiotics, and pressors. We didn't have the means to keep patients who were otherwise would be considered dead alive, very, very realistically alive, physiologically, almost indefinitely. So it's not quite that easy when you say, I'm not going to treat because you're overmastered by your disease, when you have an acute illness that I can very easily treat. Futility is a proportionate relationship. The question of futility comes up a lot, and it's very, very challenging to define it per each patient. It's a fluid process. It's not a mathematical calculus, which we all, being scientists, I consider myself a scientist of sorts. We'd like to have a nice, clean way to calculate, okay, boom, there it is. And many have tried that. But this is proportionate to what the patient sees as what is beneficial to them. We help them with that decision by advising and giving them information. Again, back to the communication. But they also determine what the burden is. And we have patients who feel that very clearly effective interventions such as blood transfusions, such as dialysis or other interventions, for various reasons or deep beliefs, they feel that that is something that would be negative for them, that it would be harmful to them. It could be spiritual, it could be otherwise. It could be financial. And they will refuse to do it. Patients have the right to do that. And we need to gain an understanding as to why they make those decisions. And it's tough. It's really tough. But sometimes we do that. We have, in treating patients with anorexia nervosa, eating disorders, we have not infrequently sent them home on hospice for a very treatable condition, which for them was untreatable. So there have been those who've tried to create a mathematical analysis of futility. Lawrence Schneiderman in California, UC San Diego, offered a practical, quantitative approach to calculating futility. But in the end, he had to take into account that exceptions need to be considered for patients' preferences and values, that the subjective is unavoidable in doing this. And when we talk to our patients about end of life, about making end of life decisions, about how far do you want to go, and trying to create treatment plans, we must take into consideration what their belief system is, what their values are, what their understanding is, and how we can influence that thinking, not to coerce them, but to enhance their decision-making process. Futility is a fluid process that may go on for years with that patient in the discussions that you have, because the data that comes in and new information that derives and how they're doing, whether their family has come to visit them or not, has an impact on their value of life and whether they think life is worth living or not. Schneiderman definition of quantitative futility, which for Schneiderman was 100 consecutive failures of treatment for that particular entity or that particular intervention. Now, I don't know about you, but I can't remember the last 100 cases of intubation that I was involved in, or the last 100 cases of dialysis that I was there. But wouldn't it be cool if we had big data that could go into our EMRs and look at those last 100 cases to find out what the outcomes were and what the variables were that influenced that outcome that is there. And there's work that's being done, and I think you guys are probably doing some of that work as well. Conclusion in this empirical basis and empirical analysis was that it can't be done. I mean, it's really not advised to try to do that. So this is a very tragic situation of a 25-year-old, 16-week pregnant young woman who admitted to the MICU with viral meningitis and basically became brain dead. She had an MRI revealing uncal herniation, cerebellar tonsillar herniation, midline shift, and her Glasgow coma score was 3, but it's the lowest possible score you can have. Outlook was nil from a medical standpoint. And had maternal fetal consult at that time, 16-week pregnancy, who felt that sustaining the body of the patient as an incubator for the fetus was not viable. That just couldn't be done. Neurosurgery saw her and felt that palliative care was indicated, and more importantly, comfort care and assess for brain death. And the family wanted to withdraw the vent and put her on comfort care, which is aggressive end-of-life care, while the patient's dying, because she wouldn't want this. Obviously, the care team was very distressed, but they're also distressed about the potential legalities of this, this being an unborn child's life, who we were dealing with as well. And here I just refer to the Munoz case of a similar situation, 14-week pregnancy, of an individual who was in fact brain dead, and the hospital refused to withdraw from the vent because the Texas law where this patient was required that a woman be maintained on life support until she gives birth. But after 2 months of sustaining her, withdrawal was allowed because the law did not apply to brain dead individuals. They shifted their course on that. You can see how complicated the futility question can get when it gets into the courts. I was an advisor in representing the Council on Ethics and Judicial Affairs for the AMA for the Uniform Determination of Death review that was done by the Uniform Law Commission that originally wrote the law in 1980. And as you know, this was adopted in 50 states. It was, and it offered two options for defining death. One was the one we've always had, irreversible cessation of respiratory and cardiocirculatory function, and the other, irreversible cessation of all functions of the entire brain, including the brain stem. We've deployed that many times in our institution, and it has been relatively effective, although we've had situations where families have really resisted that because they wanted to keep their loved one alive. It was seen at the time, in 1980, that both were equivalent, that it was felt that the brain could not survive. If the brain did not survive, then the body would not survive. There would be a natural downhill effect to where physiologically the body would just shut down. Well, we found out that that's not the case. There have been many cases, where individuals have been kept alive, brain dead, and their physiology persists. Their hypothalamic function maintains, they grow hair and nails, they're able to gestate, they go through puberty, they're able to absorb nutrition, excrete waste. So we know that the parts of the brain, related to the autonomic system and other components of the brain that requires homeostatic control, maintain themselves. And my neuroscientists try to explain this to me, and I don't have a full understanding of it because there isn't a full understanding of it right now. But they debated this for 2 years in terms of modifying this to somehow make it fit in with the new understanding of the neuroscience that was out there. The UK had adopted a consideration of revising it to irreversible apneic unconsciousness, which was the new brain dead. But the concern about this, the ethics concern about this with the slippery slope was the potential harm this might convey to the disabled. And part of the disabled would be those who are neurologically severely impaired and not functional. And then perhaps the biggest elephant in the room was the concern about cost of care, maintaining these folks in long-term care facilities, which we have here in town, and the loss of transplantable organs, which was a huge utilitarian issue for this. Ultimately, the commission stopped meeting, and they decided to leave well enough alone because it seemed to be functioning relatively well across the country. I have no idea where that is now, but a lot of people are writing about it. So what do we do from here forward? We need to consider the influence on both care and treatment of the science that you're creating. What does this wonderful data, this new science, these new interventions that you are coming up with, how does this impact the conversation that we have? How does this impact the shared decision-making that clinicians have at the bedside? And remember, you're part of the team now, right? You're at the bedside there with us. So how does this influence that discussion? How do we harness big data and AI to improve that decision-making and enhance trust at the bedside? It's all about trust. Communication, trust, they go hand in hand. Being there and ensuring non-abandonment, all of that goes hand in hand. Engaging key stakeholders in these discussions, I think, could be very useful. Dr. Brandt would like nothing better than to be on another committee to talk about some of these research questions that are there. Our palliative care team, one of the best in the country, is available to have these discussions. And of course, clinicians. We've got some clinician scientists here in the room that are superb, that are amazing. You know them. They're great. Let's get more of them. And let's start having those discussions. Incorporating research into healthcare education and training. There are some institutions that do this and do this very well. There's some that don't do it at all. When I was in medical school, I had no research training per se. I knew about research, and I would read about research. Some of it I understood, but I didn't have a hands-on experience in that to really be able to empathize with the work that you do, and certainly not in training. I think if I had had a year of research in my residency, if that had been offered, I might be sitting out there with you. I might be Bill Fay. Nobody can be Bill Fay. But I mean, this is the kind of influence that can have. Let's reimagine the physician-scientist workforce through our collaboration. And let's bring more people to the table and do that. I know our chair of medicine, Dr. Honcover, would love that. We have room in the budget for that, I'm sure. Dr. Honcover, do we not? Yes. So let's do that. And then promote and incentivize mentoring, which is a broad scope. It's a broad brush. I'm a big fan of mentoring. Some of my best experiences in my professional life have been through both being mentored and mentoring. And I think that really is what closes the loop and I can make forward. I've just got a couple more slides here before we stop to sort of underscore what I've just been saying. This is we've been talking about predictive modeling, how we access our patient experiences and the information we already have out there to really inform decision making now. This is a study using nursing EHRs that examined for comfortable death outcomes in end of life in patients suffering from death and anxiety. And they had several measurement tools that they did with this. But the bottom line on this is that the multiple models can be used for predictive modeling in really being able to intervene with patients that have end-of-life anxiety. And that have a robust capability as a base in decision making and support the framework for nursing. I mentioned the physician scientist. We have very few that are out there. We have that has gone down over the past 30 years in terms of the number of individuals who are both clinically and research grounded. There are a lot of competitions for the physicians and for our nurses and for other healthcare professionals on the team to be involved in the work that you do. A lot of it's financial, a lot of it is administrative, a lot of it relates to the dearth of mentorship that's there, that they don't have these amazing folks that are out there that can really bring them into the fold and do that. We have a phenomenal MD PhD program. I know that we've just recently expanded the number of candidates that are coming in. This is great. Why not do this for RN PhDs? Why not bring our occupational therapy and physical therapy colleagues in to have this? Dr. Brandt has a doctorate in occupational therapy. and is utilizing that in some of the research that you're doing with bedside communication. So I think that these are things that we can embrace and that we can effectively deploy for the betterment of the good. I just found this yesterday. This just was published yesterday in the Journal of Neurotrauma. And it's, the title is Recovery Potential in Patients Who Died After Withdrawal of Life-Sustaining Treatment, a TRACK TBI Personality or Propensity Score. The TRACK TBI represents 18 sites. Some of you may know about this database. It is big data that's quite big that really looks at life-sustaining treatment in patients that were withdrawn and those who were not withdrawn. And the bottom line to this was, and I didn't read this whole paper, I pulled it up yesterday afternoon, is that it suggests that a substantial proportion of patients with TBI and withholding treatment may have sustained or may have survived and achieved at least partial independence, even though death comes to many of them as they're withdrawn. This is the kind of information that would clearly impact decisions and shared decision-making we would have at the bedside of patients with this condition in making a determination about, are we going to withdraw and allow your loved one to pass? We have the capability of this, and some of you may be doing this. I don't know all the science that's occurring now. I know a lot of good science is happening. But these are just some ideas that are there moving forward. I want to end with, I started with a clinician, and he's the best kind of clinician. He was a general internist, Ed Pellegrino, who also is one of the fathers of bioethics, happened to be my mentor. But I'm going to end with a scientist, a basic scientist who was not a clinician, but who was at the bedside, Pasteur, Louis Pasteur. And this is particularly relevant in today's socioeconomic environment, sociopolitical environment, that one doesn't ask of one who suffers, what is your country and what is your religion? One merely says, you suffer, and I will help you. So I want to thank you for your attention, and I look forward to comments and questions from you. Thank you very much. Yes, ma'am.
Yes, for biological sciences and mentor of many students.
Thank you.
Some of whom had to drop out of that program. It's just so demanding for them to be PhDs, so that's my answer.
I can't even imagine.
But I have a question about the cost of debt. You brought in a lot of decision makers in the process. You've got the state legislature, you mentioned it. We went to the post-row era. But who pays? I mean, it must cost a huge amount to keep someone who's 14 weeks pregnant alive, well, functioning long enough for this fetus to survive if it can.
Yes.
And that must be hugely expensive.
It is.
And who covers that? If the state legislature demands it, are they getting funding for it?
Yeah, cost is, every conundrum in medicine ultimately, and in healthcare, ultimately comes down to who's going to pay for it, is the cost of it. And the more technology, the more therapeutics, the more interventions that we have, that we throw at, the more intervention that we have capable of keeping patients alive longer and sustaining them, they're more and more expensive, to the tunes of millions of dollars oftentimes. They literally get a bill for millions of dollars. Most patients don't have that. I mean, insurance will cover a certain amount if you're lucky enough to have health insurance. 10, 15% of our population have no health insurance at all, which means they don't have access. And they become, in essence, wards of the state quite often. And the state will end up paying for that, which means that our tax dollars pay for that. And so this is a real issue. We have federal dollars, we have, and I'm not a health policy expert, but I know a few. They come from federal dollars, they come from state dollars, they come a little bit from private industry, but much of it is just absorbed by the systems. And there are times when they get shifted from system to system because the system just says we can't pay for it anymore. Most of them are geared toward, in long-term care, long-term acute care facilities, they have a whole financial structure that will support that if you can get them in. It's a real problem. I mean, we have created that through our science and through what we have done. You know.
We've got a number of great questions on Mentimeter. I want to get to them. In your wildest dreams, what could AI do for end-of-life care?
It would have patient available information, when I say that, I'll say three things. First, it would have informatics available to patients, internet, whatever digital device they've got, because most patients now do their own homework. That is good. And where AI, and the concern about AI is the potential abuses that could be there, and whether the information that AI provides us is sound from the resources that it derives that information from, and also from other false resources where it's intentionally made false. So to where AI, we can regulate it to the extent that it will provide sound information for patients and families. It will support the decision-making that we clinicians have, that we take to the patients in sharing this. And that it will come back and inform the science that informs the AI. It's a feedback process. So now, how do we do that? I don't know. That's why I'm here, right? That's your job. I don't know how to do that, but and that's a broad stroke. Yeah.
The next question online is, Dr. Fleming, many of the examples you've cited, and I know of many others not cited, point to the lack of communication or cooperation with policymakers, indicating the need to address this. Do you know of any examples or efforts at MU or other places that could bridge this lack of communication?
Well, yes, we have many individuals here in our own system that are very involved in advocacy, that have working relationships with policymakers. We have a Center for Health Policy that is very much involved in that. We have individuals that are here as well. Our university, they have a whole office that is involved in engaging policymakers, engaging the state and others, institutions, and developing policy that can be beneficial for healthcare and also for the bottom line. In other words, that can help control costs and help control overutilization. So the resources are out there. I would start by going online and seeing what the university website and what our medical school website has to offer, or our health system has to offer. But there are people doing that, and not without some success.
So another one from Mentimeter. When consulting on a case with competing opinions within a patient support system, how do you maintain
I didn't hear the first part of that. I'm sorry.
Okay, consulting on a case with competing opinions within a patient support system, how do you maintain objectivity?
Leah? Okay. I'm a big fan of listening. I think that the strongest value anyone can come to any kind of discussion or communication is the art of listening. And really hearing what the perspectives are of each individual within the discussion, especially if they're in conflict. And then encouraging those individuals to communicate about it. It's trying to be as objective as possible in healthcare ethics. It's all about the patient, but it's also about the others who the patient embraces as being important to their life, which includes their family. And it also includes the care team. So it's hearing all of those perspectives with keeping the eye on the ball, that it's patient welfare that is the most important. And when I do consults, I keep coming back to, okay, we're talking about your mother or your father. We're talking about what's really in her best interest, not what you want particularly, but what do you think she or he would want under these circumstances, and reminding ourselves. Doing it respectively, doing it openly, being an active listener. It's all those communication skills that we, learned in wherever we learned them. And, but just being active and engaged and respectful and listening well. There are times when the conflict is irreconcilable. There are times when they're just irreconcilable, and we have to use other sources, legal or otherwise, to resolve them. An absolute last resort for physicians is to transfer the case. Don't advise that, but I've seen that happen before, or for the patient to actually transfer their care to another institution. But in a system like this, we can't say, I think I'm going to go home now. We're kind of in it for the long run. And so we have to hang in there. IBID, the burnout phenomenon that we have and the exhausting phenomenon that we have. And all you have to do is talk to any of our clinicians, and they'll tell you what the issues are.
Thank you so much. One more? Okay. Okay. It seems challenging and critical to involve palliative care or palliative medicine as early as possible, but thoughts on how early might be too early?
Yeah, you really can't be too early. I've always said that if you think this patient might be a candidate for palliative care or for a palliative care consult, you're probably already too late. I think that if you think their advice can be helpful, bring them in. Let them see the patient. Let them give you their insights into what next steps might be beneficial to them in helping them. Whether it's a withdrawal of treatment or a withholding, regardless of what the circumstances are, palliative care is just that. It's enhancing the care and relieving the pain and suffering of our patients. They may not be actively dying in the process, but palliative care, the whole theory around palliative care is simply comforting the patient and improving their care environment as such, whether it's a dying process or not. So I'm probably creating a lot more work for my colleagues on the palliative care team, and so I'll just tell them you're welcome on that. Because they like to be involved and they like to be there. I think, Leah, you had your hand up.
I do, Bound, if there's time or not. Just really quickly, maybe for this group, I think if you could end with, we've been studying a long time that inverse correlation between access to really sophisticated technologies that we have in the U.S. healthcare system and really poor health outcomes. And now we have data analytics and all these things that we're using to try and improve quality, and we keep getting worse and worse and worse and worse. And so I'm just wondering what your thoughts are on how we maintain that perspective of really thinking about the patient first and health outcomes and well-being in this trend that we're seeing as a whole.
Thank you for that question, because that underscores the theme of my talk. And my theme is it's not about the data, it's about the patient. It's great to pursue data, but the work that we do is, we need to ask ourselves, how is this truly going to impact the patient? How is this going to impact that conversation it's going to be that we're going to have? So I would say put the patient first, put the data second, and let the patient experience inform the data acquisition. Not an easy thing to do.
Dr. Fleming, I really, really appreciate you sharing
you.
your work with us and all the
Yeah.
work that you've done. I would like to give you this token of our appreciation
Thank
for sharing your work. Thank
great.
you so much.
Well, thank you.
Uh,
to be here.
Thanks for joining, everyone. Please join us on June 25th for our next speaker. Dr. Tae Chung from Johns Hopkins is going to be talking about a relatively rare disease, postural orthostatic tachycardia syndrome. Sometimes we refer to as POTS, which has also more recently been associated with COVID infection. So it should be an interesting talk. He has a specific clinic helping people that are impacted by POTS. So please join us on June 25th. With that, let's give Dr. Fleming another thanks for his excellent
Thank
talk.
you. I appreciate it.